All right, let's jump right in. We're going to tackle a topic that is the absolute bedrock of any emergency: airway management. It is priority number one, the most critical first step, and today we're going to demystify why that is. So let me ask you this. Picture a crisis. Someone collapses right in front of you. What's the very first thing that pops into your head? Chest compressions? Shouting for a defibrillator? Well, you might want to pump the brakes on that thought, because as important as those things are, and trust me, they are vital, they aren't job number one. The real first priority is something that's so easy to overlook in all the chaos. And here it is, the big reveal. It's all about the airway. Think about it. Without a clear path for oxygen to get into the body, nothing else matters. CPR, shocks, they're not going to work if the body's starving for O2. So the first, last, and always priority? It's the airway. Okay, so we know it's critical, but you can't fix a problem if you don't even know it's there. So how can you tell if someone's airway is blocked? Well, you have to know what to look for, and maybe even more importantly, what to listen for. So what are those sounds? Here's a huge tip. A clear airway is a silent airway. A quiet airway is a happy airway. If you hear any kind of noise with breathing, that's your cue that something is wrong. And get this, each of these sounds is like a clue in a mystery. A gurgling sound, that probably means there's liquid, like vomit or blood, in the way. Snoring, that's the classic sound of the tongue falling back. A high-pitched squeak or stridor, that tells you the blockage is way up high. The bottom line is any noise is a big red flag. But what about the scariest sound of all? Silence. That could mean a total blockage. And this is when you stop listening and you start looking for something really specific called seesaw breathing. It's this strange paradoxical movement where the person is trying so hard to breathe that their chest actually sucks in while their stomach pushes out. It's a gut-wrenching sign that zero air is getting in. All right, that sounds terrifying, I know, but here's the good news. The first and often the most effective things you can do require absolutely no equipment. You don't need a bag full of fancy gear. All you need are your hands. Let's see how. We're talking about 3 basic but super powerful moves. The head tilt and chin lift work as a team to literally pull the tongue forward and out of the way. Because in an unconscious person, that's the most common culprit blocking everything up. The jaw thrust does pretty much the same thing, just a different way. And honestly, for most unconscious folks, one of these simple moves is all it's going to take. Now let's switch gears. What if it's not the tongue, but a piece of food? Choking. You have to figure out in a split second, is this a mild problem or is this a severe, life-threatening one? The easiest way? Just ask them, are you choking? If they can answer you, cough hard or breathe at all, it's mild. Your job is easy. Encourage them to cough. But if they're silent, if they can't make a sound or have a weak, quiet cough, that's severe. You have to jump in right now. So for that conscious adult who's severely choking, here's the playbook, step by step. First, lean them forward and give 5 really sharp back blows right between the shoulder blades. If that doesn't work, you immediately go to 5 abdominal thrusts, what most people call the Heimlich maneuver. And you just keep switching back and forth, 5 blows, 5 thrusts, 5 blows, 5 thrusts, until that object comes flying out. So sometimes those hands-on moves just aren't quite enough to keep things open, especially if the person stays unconscious for a while. That's when we level up to some basic equipment, simple airway adjuncts. And really, all these little gadgets are designed to do is take over the job your hands were doing. They're just simple physical props that you insert to hold the tongue and soft palate out of the way, keeping that pathway for air wide open. You've basically got 2 main flavors here. The oropharyngeal airway, or OPA, goes in the mouth. It's super effective, but, and this is a huge but, you can only use it on someone who is completely out of it. If they have any gag reflex at all, it's a no-go. Then there's the nasopharyngeal, or NPA. That one, you guessed it, goes through the nose. It's way better for people who aren't totally unconscious or if you physically can't get their jaw open. Okay, we're heading into the deep end now, the advanced stuff. And let's be super clear. The goal here isn't to turn you into an expert on how to use these things. It's to understand why they exist and where they fit in the ladder of care. First step, you got supraglottic airway devices, or SADs. You can think of these as the perfect middle ground. They're way easier and faster to put in than a full-on breathing tube. You basically slide it in, and it forms a nice little seal right over the top of the voice box. It gives you a much more secure airway than a simple mask without all the high-stakes risk of the next thing we're going to talk about. And that brings us to the most advanced technique of all, tracheal intubation. And this quote, wow, it really says it all. Putting that breathing tube down the wrong pipe into the esophagus instead of the trachea and not realizing it, that is the absolute worst-case scenario. It is a fatal mistake. And this is the real tug of war with intubation, you know? When it works, it's considered the gold standard. It protects the airway perfectly. But man, the downsides are huge. There's a real risk of messing it up. It can cause long, dangerous pauses in chest compressions. And for people who don't do this procedure every single day, the failure rate can be shockingly high. So, with stakes that high, how do you make absolutely sure you got it right? How do you avoid that catastrophic mistake? The answer is this amazing piece of tech, waveform capnography. It's pretty simple, really. It measures the carbon dioxide they're breathing out. If you're in the lungs, you'll see a nice, steady waveform of CO2 on the monitor. If you don't, you're in the wrong place, period. It's become the non-negotiable safety net for this procedure. And that really brings us full circle, doesn't it? We've gone from a simple head tilt all the way to advanced tubes and high-tech monitors. But what have we learned? The more complex you get, the more risk you introduce. So it leaves you with this one big question to chew on. In that race against the clock, when every single second counts, isn't mastering the simplest, most fundamental technique often the most powerful skill of all?